I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke. We know that in some strokes, TPA and mechanical thrombectomy both fail to remove cerebral clots. Has it got to do something with clot composition? This is exactly what we will see now. So, these are all stroke thrombi, and we can see that they come in all different shapes, sizes, and color. This is a collection from Thrombi Research Lab in Belgium. So every patient who undergoes mechanical thrombectomy, the material that comes out has to be sent to this laboratory for analysis. So what they do is they do the histopath. So H&E staining and MSB staining, platelets and RBCs in the clot have been marked as P and R respectively. So we want to see if the clot is platelet-rich clot or an RBC-rich clot. Now, if we stain this with platelet-specific dye, it will appear purplish like this. And this is a study of 161 clots retrieved from patients. Some are platelet-rich, as you can see, completely purple clot on the left here, and some are RBC-rich clots here, but the maximum you can see is a mixture of both RBC and platelets. Now, if you do fluorescent staining of the RBC-rich area, you can see these green filaments here. These are all fibrin, and they are holding together all the RBCs. So, RBC-rich area is a simple structure with RBCs being held with fibrin. This is an electron microscopic picture of the same RBC-rich area, and you can again see RBCs packed together with fibrin threads. Now, if you stain RBC-rich area with all the other stains, nothing else comes up except for red blood cells and the fibrin, green fibrin. But when you do the purplish 1 Willebrand staining for this platelet-rich area, and you can see here that these black burrows that you can see in the platelet-rich areas have actually been stained purple here, and these are of 1 Willebrand factor. So the question is it 1 Willebrand factor that is holding these platelets together in addition to fibrin? So one of the ideas was that maybe 1 Willebrand factor is an important part of the structure for some clots holding everything together and could be a potential target for thrombolysis. We know that normally TPA acts on the fibrin, but maybe we should target 1 Willebrand factor separately. So platelet-rich clot was introduced into cerebral circulation of mouse with special maneuvers. An enzyme that could cleave 1 Willebrand factor was used. This enzyme is called ADAMTS13. In mice, it was tested and special treatment was used to generate these platelet-rich clots, which was then injected into the mouse cerebral circulation to cause a stroke. Now, this enzyme was successful in breaking these platelet-rich clots, whereas TPA alone failed to cleave these clots. So, this enzyme can help TPA for cerebral recanalization, and this enzyme is now going through further trials. But then we can also see in the platelet-rich area, there were some bluish material which were actually leukocytes. So there were many of these in cerebral clots. Many of these leukocytes are actually neutrophils, and neutrophils can form neutrophil extracellular trap or nets. These nets are actually DNA material which comes out of neutrophil when it explodes. These nets are very prothrombotic. RBCs, these ones, RBCs stick with it, platelets not only stick with it but also get activated and coagulation cascade starts. So maybe these nets are responsible for keeping the clots together. These brown material seen are all nets. So then DNase1 was tested, which could cleave DNA. This DNA could not be produced in a clot and therefore could not have been tested in animal models. So fresh clots when received from stroke patients were tried with TPA alone versus TPA plus DNase1, and the latter clearly showed superiority over TPA alone in breaking the clots. DNase1 is already in use as an inhalational drug for cystic fibrosis. Now, what we know so far in conclusion, red blood, rich components and platelet-rich clots. So RBC areas are simple and only have fibrin and are susceptible to TPA and mechanical thrombectomy both. Platelet-rich clots on the other hand have fibrin, 1 Willebrand factor and DNA in addition to platelets and are more resistant to TPA and mechanical thrombectomy. So maybe it's time to think about improving effectiveness of TPA by making a cocktail comprising of TPA, ADM, TS13 and DNAs against stroke clots. Who knows, maybe in future something like this might come up. So can we do something from this knowledge other than looking for new thrombolytic targets? So does it help us determine the source of clots and does it affect treatment procedure? So this is one of the largest studies that looks at the etiology of stroke. It shows that cardioembolic strokes are mostly platelet-rich clots. So these are the resistant type of clots. Now this is another study of 187 clots which again confirms that cardioembolic strokes are mostly RBC dominant clots. And cardioembolic thrombi have higher proportion of fibrin, platelets rich, less erythrocytes and more leukocytes than non-cardioembolic thrombi, which we've already discussed. Now the next question, does this clot composition affect thrombectomy success? Some clots are easier to remove than others. Why is that so? So conclusion from studies is that RBC-rich thrombi are easier to retrieve via thrombectomy. More the RBCs you have, easier it is to remove that clot. Similarly, clots with more nets are harder to retrieve via thrombectomy. So RBC content is lower in these clots. Here you can see the groin puncture to recanalization time and the number of passes needed to retrieve the clot on y-axis, and on x-axis you can see the number of nets which have been measured by elastase in this study. More the nets are present, more passes are needed to remove this thrombus and hence longer the recanalization time. So what we know so far is that RBC-rich clot is soft and friable and the dense fibrin or platelet-rich clot is sticky and tough. This is what we know in addition, and this is what this experiment exactly shows. So if you see here, you can see that this fragile RBC-rich clot is being retrieved. So through aspiration, but distal embolization happened. Now going through with the stent retriever, and at the end, it still distally embolizes, and you can see it embolizing now. And what about the platelet-rich sticky clot? So you can see here that this clot is being retrieved with a stent retriever, but it becomes more and more compacted as the stent is trying to pull it. It is sticky, the stent still fails to take it, and in fact it has become more compacted and more difficult to remove in the second attempt. How sticky the platelet-rich clot is, you can easily see here that this is the RBC-rich clot and this is the platelet-rich clot, and you can see how sticky this one is. Next question is if we can get an idea of clot composition on imaging. Can we predict it? This can give us an idea in advance if the clot will be amenable to lysis and if it will be easy or difficult to retrieve. So many studies available on this. They showed that hyperdense MCA sign labeled as HMCAS here. This is the hyperdense MCA sign. On CT, this is plain CT brain. This is typical of clots that contain high amount of RBCs. Similarly, on MRI, a booming artifact especially has a correlation with high amount of RBC content. So it seems that amount of red blood cells can somehow be estimated on imaging. So RBCs in thrombi increase Hounsfield unit signal. This is again the hyperdense MCA sign, easily visible here. Without giving contrast in a plain CT brain, you can see the MCA. So that's a blocked MCA, thrombotic and RBC rich. So different studies, one of them very interesting, and what they've shown is that for organized inelastic hard fibrin rich clot, they recommend aspiration as the first choice because there is low risk of clot stripping during aspiration. Whereas with stent retrievers, it's harder to be incorporated into the stent cells. Now, this is for the fibrin-rich clot. Now, for the RBC-rich clot, this is fresh, this is elastic. The first choice they've recommended is a stent retriever. It's easier to be incorporated with the stent cells. Why not aspiration? Because it is friable clot, high risk of clot stripping and fragmentation during aspiration, and they recommend that there should be larger inner diameter catheters available that closely match the vessel diameter, and through them you can then do the aspiration for these clots. So very interesting how people think about these things. They come up with these questions, they try to find their answers, and that's how they come up with new innovations. Thank you.